Hi, I'm Dr. Nathalie Johnson, and I hail from Portland, Oregon. I'm honored, privileged to be talking to you today about de-escalating breast surgery and when less may be more. So I have nothing to disclose, and I'm inviting you to just sit back, relax, and listen. So what I'd like to go through today is talk about how we can get to breast conservation. Sometimes when we have sticky situations, big tumor, small breast, talk about oncoplastic approaches so that we can get to breast conservation in more challenging situations again. Talk about expanding indications for nipple sparing and touch on our go flat movement. So what are challenges for surgeons when it comes to breast conservation? Well, there are a few. When you have a small breast, but a sizable tumor, when you have a full breast, but there is a large area of involvement or multifocal or multicentric disease involving multiple areas in the breast. Extensive areas of ductal carcinoma in situ are also very challenging when we want to go with breast conservation. So what can we do when we have invasive cancers and they're large? And we want to save the breast? Well, the best way to do that is neoadjuvant approaches to therapy. So it's very straightforward when we're talking about triple negative or HER2 positive disease. And those are often treated with neoadjuvant therapy in any circumstance. And that is because we know now that downstaging or treating with neoadjuvant therapy allows us to understand response to therapy. And for patients that have residual disease, we can offer additional therapy to improve their overall outcome. So one of the things I want to mention here is if you're using chemotherapy for downstaging patients, upon completion, you want to get those patients to surgery within 4 to 6 weeks of their last chemotherapy dose. I included a reference at the bottom, which is a study that we did showing that the time to surgery can impact patients' overall survival. In my opinion, you don't need to do repeat staging with MRI. It's done quite frequently, but I stopped doing it because there are times when the MRI suggests there's still extensive disease, even though clinically the patient has improved. And so I, in the past, have removed patients' breasts based on the MRI findings only to find out that they had no residual disease left. So if a patient downsizes clinically, I will usually give breast conservation a shot because I think it's easier to say we tried to keep your breast, but we got margins and we have to go to mastectomy. But it's a little more difficult when a patient really wanted breast conservation and you do a mastectomy and say, actually, there was no residual disease. So that's my recommendation for you. I like the idea of doing neoadjuvant treatment as well because it gives you time to do genetic testing and have patients really think about what they want to do with their breast tissue. So downstaging with neoadjuvant therapy for hormone receptor positive breast cancer is a little more tricky. It's divided into post and menopausal and premenopausal women. I'll start off with the postmenopausal women because there's actually really good, strong data that postmenopausal women with luminal A type tumors really respond very well to neoadjuvant endocrine therapy. And in fact, they will more often get to breast conservation than they would if you used chemotherapy. And this is no matter what the tumor size starts out at. I very often will use genomic testing if I'm not clear that the patient has a luminal A tumor. Because if they don't, then those are the patients where I would go with neoadjuvant chemotherapy for downstaging. On the converse, when you have a premenopausal woman, endocrine therapy is not as successful in downstaging tumors. So you really have to set realistic expectations for that. I do want to point out here that African-American women using genomic testing with OncoDX may not be as accurate for them. And I'm going to show you a little bit more data. The other thing about premenopausal women is that sometimes in addition to tamoxifen, you may need to add ovarian suppression to really see tumor downstaging. And this is definitely not risen to standard of care. Overall, there are not a lot of studies done on premenopausal women, but it definitely is an option. So let's just pause and talk about TAILORx and African-American women and outcomes. So I just wanted to touch on TAILORx, which showed that on average, Black women for the same recurrence score had worse outcomes, significantly so. Dr. Hoskins and his colleagues actually took a deeper dive at this finding from the TAILORx study. And looking at all comers, African-American women in general tended to have higher recurrence scores, but specifically the death rate for Black women with node negative low risk recurrence scores was higher. And that led him to think that maybe the OncoDX may need to be recalibrated. And I should say that he looked at 86,000 patients in the SEER database and came to this conclusion. So I would say that maybe for African-American women, you may want to consider using MammaPrint Blueprint to understand what their real risk and possible benefit from chemotherapy would be. So with MammaPrint Blueprint, on average, African-American women also have more often high risk scores. But I want to point out this study done by Dr. Nunez and colleagues, it was in 100 patients. So it's a small study. And in that study, there were 29 patients that had both an Oncotype DX and a MammaPrint performed. What I want to point out to you is looking at the breakdown of those patients. You can see that 2 of the patients had high risk onco scores and also MammaPrint high risk scores. 8 of the patients came in at intermediate risk, and 4 of those 8 were MammaPrint high risk. But more importantly, the very last line there were 19 patients who came in low risk on onco, and 8 of those 19 were MammaPrint high risk. And I think this is probably where we're seeing the poorer outcomes in low risk node negative Black women. So again, very thoughtfully, when you're doing genomic testing in this particular group, think about whether you should use onco or MammaPrint. So how do we translate all of this information, genomic testing, downstaging, into saving breast? Traditionally, we've always used chemotherapy for large tumors, but now we know that biology rules. And so if you have luminal A biology, it's best to downstage with endocrine therapy. And again, this is most relevant in postmenopausal women. So let's look at Z31, because this study is focused on postmenopausal women with clinical stage 2 and 3 disease. It used aromatase inhibitor therapy, and 377 patients enrolled. And the overall response rate was almost 70%. But here I want to point out that 51.5% of the patients who were felt initially to need mastectomy were able to downstage to breast conservation therapy. Now, if you want to do this, the ideal time frame for neoadjuvant endocrine therapy to get to breast conservation is 6 months. I've done as short as 3 months because some people respond very rapidly, but if you really want to downsize to the best of your ability, I guess I would say. 6 months is a good window. And actually in Europe, they've now gone out to 1 year. So I want to look at the use of neoadjuvant endocrine therapy in postmenopausal women. Prior to Z31, about 2% of stage 2 ER positive women were offered downstaging with endocrine therapy. And after Z31, it rose to a whopping 2.4%. And you can see for stage 3, ER positive postmenopausal women, it was a little over 6%, and it rose to a whopping 7.4%. So clearly this is their group of patients that we could be salvaging their breast with neoadjuvant endocrine therapy. And we need to do a better job, I think, at selecting those patients out and offering them this option. In the axilla, and I'm not going to go into this in too much detail because I know we're having another talk about downsstaging in the axilla or de-escalating therapy in the axilla, but just wanted to point out that with luminal A or hormone receptor positive breast cancer, downstaging the axilla with neoadjuvant chemotherapy is not that much more successful than it is with endocrine therapy. With luminal Bs, it's anywhere from 10 to 21%, and it's about 15% with neoadjuvant endocrine therapy. So let's transition to actually talking about the surgeries that are an option. So I wanted to go over bilateral reduction mammoplasty and staging that to nipple sparing mastectomy. So there are times when we know that we need to take a patient or the patient needs a mastectomy. We're not going to be able to do breast conservation, but the patient would like to have nipple sparing. So we're extending that option. As you can see pictured here, there's a lady with very generous and tautic breast who needs mastectomy, but would like to have nipple sparing. When the breasts are this large, sometimes it makes sense to do reduction mammoplasty first. You can get out the cancer, check the lymph nodes, and make the breast pocket smaller, lift the nipple into a good place. And then you let the patient heal, and you come back about 3 months later and go to completion mastectomy. Now you can do nipple sparing much more easily because the nipple has had a chance to set and reestablish blood supply. And you've made the skin pocket smaller. So this option is good for patients with hormone receptor positive breast cancer or ductal carcinoma in situ, because those patients then don't have to go on to therapy. You can keep them on endocrine therapy while you're waiting for their breast to heal and then go to completion mastectomy. This is not a great option for triple negative breast cancers because you don't have the luxury of keeping them on no therapy for several months to let the breast heal. This is also not a great option for HER2 positive or a more aggressive biologies. So I just wanted to show you a picture of a patient that we did this on, and you can see she had extensive ductal carcinoma in situ. It required 3 wires. And so we did a huge resection in a reduction mammoplasty and had very close margins because obviously this was a large area, but we just let her heal and went back and did completion mastectomy several months later. So just picturing that out. This is what reduction mammoplasty looks like, cartoon, and you can base the pedicle in different ways. And then ultimately, this is a patient who went then on to nipple sparing mastectomies final, and you can see that's a pretty good result. So let's talk about other oncoplastic approaches. And I think for women with very large breasts with breast conservation, it's good to offer reduction mammoplasty. I have a picture up of a patient who had a lumpectomy and whole breast radiation 10 years earlier. And you can see that prior to her radiation, her result was good, but over the years, her breast shrunk to considerably. So this was her long-term result. She developed tumor in the remaining breast, and we did this one within a reduction mammoplasty. So again, with reduction mammoplasty, you can get out multiple areas. So you can get out tumors in medial breast, lateral breast, and then reshape and close the breast for a good cosmetic result. And finally, let's transition to the more recent go flat movement. So with all the controversy about breast implants, many women are now choosing not to have implant reconstruction, and they don't want to go through the extensive surgery that deep flap reconstructions can be, or latissimus reconstructions can be. So there is a movement called go flat. So get away from breast reconstruction. And most of the women that choose this is because they're interested in having freedom of movement. They're not worried about the societal norm of having breast. They don't want implants, and they're looking for an aesthetic closure. You can see some women decide to do lots of tattoos and make it into something that they find aesthetically pleasing, and other women don't. They can always use prosthetics. But I just wanted to touch on something I think fairly new called Goldilocks mastectomy. And I love it because it's not too big, it's not too small, it's just right. So with the Goldilocks mastectomy, what we do is use all the skin of the lower flap. So we come over the breast like this and take all this lower skin. You remove the breast tissue, but you're leaving the skin and a little subcutaneous fat. You have to de-epithelialize the lower flap, because then you bury it and you pull the upper skin down. And this is the buried lower flap, which gives the appearance of a breast. So this is one of my patients, and you can see her breasts were not exactly symmetrical, and they aren't in the Goldilocks either, but pretty close. And she was very happy with this result. So now that we're starting to do this, it kind of gives a small breast, and the patients that are most ideal for this are women that are very large, although I have done this technique on smaller women who are just as pleased with it. And it saves them from having to use prosthetics. So some women now are asking, can you do nipple sparing with Goldilocks? And I will show you a picture of a woman who had that. So this was described by Doctors Kaselith and Richardson. And this again is the same technique of saving the skin of the lower flap and de-epithelializing it, but this is with the nipple kept in, and gives, again, a small but very reasonable reconstruction without needing implants. So I think these are all things that you'll see coming forward in the future. I thank you for your time and attention. And I will stick around to answer any questions. Thank you.